Hello, everybody. We are at the beginning of our scientific program, and the first symposium opens with a very relevant and I might say hot topic of the interactions between the new coronavirus and the brain. And we will, as you may have already noticed from the program, cover the interaction between the coronavirus and brain from several different angles, hoping to do justice to the actual subject that is on many people's minds these days. I would like to point out that the symposium had been supported as an accompanying event to the main scientific program of the Synapse Neuroscience Conference by IBRO, International Brain Research Organization, and also by the Ministry of Health of the Republic of Slovenia. And we are grateful for that support. So without further ado, the first speaker is Professor Raimund Helbok, who is a professor of neurology and a specialist in neurocritical care at the Neurological Intensive Care Unit at the Medical University of Innsbruck in neighboring Austria. And his talk will cover the pathophysiology of Neuro-COVID, its clinical course, and the long-term outcomes. Raimund, the stage is yours.
Thank you very much, Mara. Hello, everybody. It's very nice to have the first talk on this important symposium. Congratulations to the 9th symposium, Neuroscience Symposium. I looked at the program, is really fantastic. And in detail, so my topic is Neuro-COVID, what it is and what it is not. I do have some conflicts of interest, but these are major scientific conflicts of interest, as I'm co-leading the EAN core COVID-19 group in the European Academy of Neurology. Also, I was co-initiating the Energy Registry, which is a prospective and retrospective registry on Neuro-COVID. Locally, I'm leading the ATTRACT study, where we look at longitudinal outcome until 1 year in COVID patients. And I'm also affiliated to the Neurological Care Society based on my background as specialist in neurological care. And I also co-founded the GCS Neuro-COVID consortium over there. Another conflict is that I do have only 25 minutes. There's a lot to cover. There's a lot to discuss. And for those who want to have more information or see some topics not discussed, please free to contact me. So this is a selection what I'm going to talk about. So how did I get into the whole topic as neurointensivist? In the very early, we recognized that patients are in the ICU, rapidly in the ICU, and they do worse. And we had an impression not only due to the pulmonary infection and deterioration, but there might also be an involvement of the brainstem. And if you can see, this publication is a very recent publication. There's still the hypothesis that the virus is affecting the brainstem, and also in long COVID, we are now discussing about potential invasiveness and potential effects. So it is true that the SARS-CoV-2 infection is a primary respiratory system infection, and the patients present like that, but we early recognized that there are additional features which involve the central nervous system and the peripheral nervous system. And the question was from the beginning on whether there's a neurotropism. And what we now know that, yes, in certain patients, we can actually see the virus directly in the brain, in brain autopsy patients. And this is affected the olfactory mucosa. You see the olfactory bulb, and also involving the brainstem and even the medulla oblongata. The limitation is that this is the selection of the very poor grade patients. And as you can see also here, PCR diagnostic did not always confirm the virus in all areas of the brain in these patients. So we actually don't know and still don't know how invasive the virus is. But what we know is that besides the direct invasion of the central nervous system, which is here the type A, there are other mechanisms how the central nervous system and the peripheral nervous system can get involved. We know that there is an endotheliopathy, which obviously happens also in the pulmonary system, but that can also happen in the brain. And that can lead to microbleeds, to larger bleeds, and also to microvascular obstructions, so minor strokes. What we also know is that there is a systemic effect in terms of the cytokine storm, the upregulated immune system, which we now try to suppress in the treatment of very severe cases, which also can be associated with affecting the brain, the function of the brain and the peripheral nervous system. So the question is, do we need CSF testing in these patients? And we have to say yes and no. Yes, because we should not oversee other neurological diseases, as they can be meningitis or other causes where we need a lumbar puncture. But no, not for the reason to detect the virus, because if we screen, there is a very low rate, as you can see here on the left side, to detect the virus, and even in patients with symptoms of the central nervous system, which is a nice summary recently published by Frontera, who's going to give the next talk. So overall, we have to say that CSF testing is not indicated unless you see focal neurological signs and you consider a lumbar puncture anyway. And in the following months, when the pandemic began, there was a rapid increase in reporting neurological symptoms of the central and the peripheral nervous system. And we are now over 50 neurological symptoms and signs and part diseases. Actually, there's nothing which is not reported in COVID-19. And the question is that all Neuro-COVID? And this brings me to very fundamental thought. If we report associations, these still remain association and do not prove causality. And this is a very important thing. And I think we are in many parts not far that we can actually say that we found the causative agent being associated with the neurological disease, even though the pandemic is already quite a long time on. One way how to analyze that on a patient-specific basis is the timing of the disease and the timing of the onset of the neurological presentation. For example, Guillain-Barré syndrome is a very good example, or stroke, or other potential side effects in this disease. So we have the viremic phase followed by the immunological phase. So this is one thing how we can differentiate or assume a potential causality of the neurological manifestations with the virus. But we also know that there is a background incidence of neurological diseases. And so it happens even with the discussion with vaccines that we will see patients with peripheral facial palsy, for example, simultaneously when we give the vaccine, and it's not said that it's directly related. Another point I want to make that we always have to look for the correct denominator. So if we report manifestations in the ICU, we know that only 1 to 3% of the patients are actually in the ICU. So this report reflects a specific patient population. Does not mean that every patient with SARS-CoV-2 infection has a prevalence or incidence of a certain complication rate of X%. And this is actually what happened. We have multiple publications. It's very difficult to overview about the prevalence of neurological symptoms and signs. And as you can see here, for example, headache, 3% reported in one case series, 66 in the other case series. And this runs through every manifestation. And maybe one good example at the beginning is also a very good and high published paper in Lancet Psychiatry, which shows that cerebrovascular events should be are reported in more than 60%. Every third patient has altered mental status due to encephalopathy or neuropsychiatric disorder. But if you look which contributors were in the registers. These were mostly stroke physicians, neurologists, psychiatrists, and ICU. So there is driven a bias towards a selective patient population. And this is also a nice summary where you can see, for example, the impaired consciousness up to 30%, up to 60% in some reports. And this makes it very difficult to get an idea about the true incidence. And we underestimate the effect on non-hospitalized patients, although I'm going to discuss about that in my talk as well. So what we started also very early is a registry, a prospective and retrospective registry, which is called Energy Registry from the European Academy of Neurology. And I can invite every one of you also as institution to still participate in contribution. So what we do, we set up a CRF and we defined the neurological manifestations in a very clear way. And now we have a lot of centers who registered to our consortium, and around close to 40 centers which are actively contributing currently to this registry. And we do have more than 1,700 patients, and there are already some publications. I also briefly touch on that later. So if you're interested in participation as institution, please go ahead and contact me. And we are now dealing with the follow-up, and we have more than 600 patients where we do have 6 months follow-up. So we try to phenotype what we see at 6 months and try to get some predictors of the acute phase to say, well, this is a patient at high risk of getting long COVID or neurological manifestations at 6 months. We also collaborate with the Neurological Care Society, as I'm affiliated to that society as well. And so we actually report a worldwide broad coverage in terms of centers who contribute to these platforms. And one of the first publications came out in JAMA Network Open, which is a combination of our registry, the Energy Registry, and then the GCS Neuro-COVID registry with patients with neurological manifestations and those all patients also without neurological manifestations. And I think the benefit or the good thing in the Energy Registry is that we have neurologists who see the patients, and this is an inclusion criteria, and this is not clear, for example, for the American cohort. So what did we find? We found that encephalopathy, stroke, and seizures are the most common neurological presentations, and already here you can see that, for example, for encephalopathy, the cohorts are different. The American cohorts mostly driven also by neurological care physicians, so more based on the ICU, have a higher incidence, and we in the registry, the EAN registry Energy, a lower incidence. So also in this cohort, you see that there are some difficulties. But the main messages of this paper is that having a neurological complication is associated with a high risk of death during hospitalization, and especially also encephalopathy is associated with higher mortality. But another important risk factor, which we know and recognized in this study, is that the pre-existing neurological disorder is also associated with an increased risk of mortality and morbidity. So if we talk about encephalopathy, there are always multiple ways how a patient, especially in the ICU, can get encephalopathic. We know that inflammation itself can cause that. We know that every sepsis patient can have a septic encephalopathy. We know that patients with pulmonary dysfunction can have hypoxic encephalopathy and the electrolyte disorders and so on. And to make that more easy for the clinician, we set together also with Frontera in the global COVID-19 Neuro Research Coalition and made a consensus paper, consensus guidance on how to diagnose, what to think about in the differential diagnosis, and potentially also how to treat encephalopathy in these patients. This paper is under review, but as many papers, it's already online. You can see the PDF as the pre-head publication is something which is going on in many of the contributions in COVID-19. So another point I want to touch on is whether in terms of the neurologic manifestations, there is a higher incidence in para-infectious diseases or post-infectious diseases. And this brings me down to Guillain-Barré syndrome, transverse myelitis, ADEM, or acute hemorrhagic encephalomyelopathy, which are all associated para-post-infectious diseases with, which are claimed to be associated with COVID-19. And especially for Guillain-Barré syndrome, we also published 2 cases at the very beginning, and we thought that the incidence is higher during COVID-19. And interestingly, after that, we didn't admit any patient for a long time in our unit. And this is also what some epidemiologic data show us, that even though at the beginning there were so many diseases associated with COVID-19, with SARS-CoV-2 infection, and we also in our report presented the antibodies in the CSF, and it was clearly associated. But the overall incidence, as shown in this study in Great Britain, was not increased. And they also report the decreased incidence of Guillain-Barré syndrome over time. And this can also be highly explained by the hygiene mechanisms which went on at that time. So no Campylobacter infection, no other infections anymore, which can actually cause Guillain-Barré syndrome. And I think the bottom line is, yes, it is associated, it can be associated, but overall the incidence is not that high as we expected at the beginning. And this is the same for other para-post-infectious disease like transverse myelitis or ADEM. Compared to the incidence, compared to how many patients are actually infected with COVID-19, the reports on these manifestations is not as high as we expected at the beginning, but it can happen. And it's obviously important to think about it. In the last minutes, I'm going to talk about long-term outcome and what we actually know. And you know all that there was the discussion very early about long-term effects. So, and the most prominent symptom was chronic fatigue. And there were a lot of also non-scientific reports about this chronic manifestation, and include dizziness, a very difficult symptom, also headache, myalgia, sleep disorder, difficulty in concentrating. And so it is very difficult also to touch base on the pre-existing neurological diseases and then what you can see in the follow-up. And that's why we very early in the course initiated a multidisciplinary study also with our colleagues on the internal medicine and infectiology about consecutive patients. And we looked at these patients, and this is a publication of the 3-month follow-up, and we realized that every 4th patient has a pre-existing neurological disease. If you don't screen properly, if you only ask for presenting symptoms at that time, and maybe through a survey, then you will include all these pre-existing neurological disease in what is potentially now called Neuro-COVID or long COVID or post-acute sequelae COVID. And this brings me to another difficult point. So you know that there is a definition of PASC, the post-acute sequelae of severe acute respiratory syndrome, coronavirus 2 infection. We defined long COVID by symptoms more than 4 weeks. These post-acute more than 3 months. And what you can see here is also, even in large series review, that there is not always a consistent definition of what we actually talk about. And we subsumize everything underneath long COVID at this stage, which is, to my mind, not the correct approach. And what was interesting and also disappointing to see that many factors contribute to that syndrome or disease. The racial minorities which have a higher incidence, rural residents, this is something which should not happen in the world these days. Another meta-analysis or systematic review meta-analysis, which report more than 50 now symptoms of long COVID or long-term effects. As you can see here, also the inclusion criteria was 2 weeks only after the COVID infection. So we cannot actually talk about long COVID or post-acute syndrome. But we have to recognize the problem. And this is also true in mild to moderate diseases. But again, here you see the inclusion criteria is more than 3 weeks, which again is not appropriate. And you can also see different incident cases. And what we have to say is that if we want to study the long-term effects, we have to prolong our follow-up beyond 3 months. This is again back our study. And as I told you at the beginning, we saw all these patients in person. So a neurologist examined the patient. And if we look closely, you can see that incident findings of neurological symptoms and signs was very high. So 60%. And this is something what is commonly also reported in some case series, but a true new neurologic manifestations only in 15%. And this is somehow, to my mind, more representative. And I will talk about 2 manifestations, hyposmia. Is it a neuro manifestation or not? This is a big question at the beginning. And we now know that the virus can affect and invade the epithelial cells, but also neurons. And in some manifestations, as you can see here, or also in the MRI scan in this patient case report, that one might see abnormalities even in the brain tissue or in the olfactorial epithelium. And olfactory dysfunction is quite a typical manifestation of COVID-19. It more occurs in mild patients. In general, it has a good prognosis, but the pathomechanism is not always clear, and especially not for long-term manifestations. And we also have a lot of patients who describe phantosmia, for example, and not a decrease of the smelling sense. And in some patients, the idea is also that there could be a persistence of virus persistence, but we actually don't know the answer for now. In our population, the self-reported hyposmia was not that high. If we made an objective testing, we identified quite a lot of patients with hyposmia. And the interesting finding here was that hyposmia, it was not self-reported in the ICU patients. We detected that by objective testing, and somehow maybe also the neuropathy, which is associated in the ICU patients. So these patients, none of these patients actually complained about hyposmia, but the objective testing was interestingly quite high, the same as in the moderate disease population and in the mild disease population. There is no treatment, no randomized controlled trial. This is the latest Cochrane database systematic review. And the last point I want to touch is on psychiatric side effects. And these are our data where you can see the prevalence of depression, anxiety, for example. And interestingly, at the same time, we had a publication, colleagues of us had a publication on non-COVID patients due to concerning depressive symptoms and anxiety symptoms. And as you can see here, the numbers, they're quite equal to what we saw in our case series in COVID patients. So the pandemic also has an effect, especially on the depression and anxiety and quality of life. But the cognitive deficits is something which comes up more and more. And in our series, it was not very common in mild patients, but in moderate and severe patients by objective testing using the MOCA score. And we are currently investigating by these pattern recognition, so prophylactic or prognosticators for several features, and for example, cognitive deficits. And we already found some signatures. The persistent pro-inflammatory response is associated with these cognitive deficits in mid and also long term, but this is still not published. So what is the pathophysiologic basis? We can use neuroimaging for that to get a more closer idea what's happening in the brain. And there are some studies which report associations with hypo metabolism in specific area and associated with memory loss or spelling loss. As you can see here, even in hypometabolism by PET studies. And if we talk about long-term neurological outcome, we can not go over the study published by the Chinese. There are some limitations in that publication, but it is a large cohort. It's the largest cohort so far for 1 year follow-up. And what you can see here is that in principle, all of these neurological manifestations improve, but a lot of manifestations are still there. So it needs even a long-term follow-up beyond 1 year. And this brings me back to my initial thought about how much the brainstem is involved. And especially in sleep disorders, we have a very active group in our Department of Neurology. And we investigated polysomnographic analysis in these patients with insomnia. And what we found is that there are phases of muscle construction during REM phase. So what we say REM without atonia, which is also seen in RBD patients. So maybe this is something where the brainstem actually really got affected, involved in the disease, and that certain patients, but it's a minority, it's very little of the population, maybe really have a brainstem manifestation. So in summary, I want to conclude that it's a disease which is a threat for patients with pre-existing neurological diseases, immunosuppressive patients on immunosuppressive therapy. Neurological manifestations are associated with worse outcomes, so we have to take care of these patients. Swelling disorders are very typical, but maybe in the variant, not as typical as before anymore. What it is not, it's not a primarily CNS invasive disease, and all these autoimmune diseases, they are there, but they are not common. And having said that, I would like to thank you for your attention, and I'm open for discussion to my talk. Thank you very much.
Thank you very much, Raimund. I am fascinated by all the new things that this pandemic is providing us with an opportunity to learn and do better. Because obviously we are forced to pay more attention to detailed history of the patients that we receive, to know whether we are dealing with a novel entity or something that is a worsening of a pre-existing condition, and many other things that you had already pointed out. I wouldn't want to hog the discussion, so let me just look at what the questions are that we have received. The first question that I see is whether long-term COVID effects are more likely to happen only in those with severe infection. But maybe you wish to add a comment. I think you answered that already.
I didn't show some parts of our study where in terms of long-term effects in critical care patients are similar to what we know in patients which are with a prolonged other disease in the ICU for a prolonged time. So critical illness neuropathy and all these side effects, this is obvious what we also see in this population. In terms of neurocognitive deficits, yes, there are some publications that they might be higher, but we always have to think, what is the population to compare with? And so an adequate population would be a sepsis population. And we know that septic encephalopathic patients do worse in cognitive function in the next 5 years. So there is anyway a decrease in also cognitive function, which we know from literature. So the question is whether this disease is more affecting the brain than other diseases. And the question is, we don't know the answer, but even in mild diseases, we see that long COVID is a problem, and especially concentration problems and the term brain fog, which I don't like because I don't think it's a medical term, needs further studies to get an idea what actually the long-term effect of this virus infection can be. But all in all, I think in long-term outcome of critical care patients, first we see what we already know from other patients, and then we have to elaborate whether there is an additional threat for the brain.
Thank you. There are additional questions. One addressing the possibility that the REM sleep disorder actually somehow potentially predicts the occurrence of Parkinson's disease later in life, but maybe a comment.
So we know the story about encephalitis lethargica, and I think there are concerns that something like that could happen. For our institution, I can only tell you we have 2 patients where Parkinson's disease was diagnosed after the diagnosis of COVID-19. It's very difficult to say that there is a real causality for now. I think we need epidemiologic data to investigate on that. But I think this is the big fortune of this pandemic, that we closely monitor our patients. So we will have the answer, and we will have the answer in a shorter time than what we saw in the early 19th century or early 20th century. And so for now, there is not a big concern, but obviously there are hypotheses, and these hypotheses, especially as the disease also starts with hyposmia, which is a symptom which also is prognostic for high-risk Parkinson's disease later on. So we will see that, but maybe even not in 1 year, but maybe later on. But many patients undergo MRI scanning, as also patients do in our institution, longitudinal. And so we will see, we will detect these patients in the population if there is a high risk.
Thank you very much. We ran out of time for the live discussion. However, there are additional questions, and we'll just, as we said before, forward them to you in case you have some free time to answer shortly. Thank you very much for your presentation.
Thanks.
So we now move on to the next speaker, Professor Jennifer Frontera, Professor of Neurology at the, Jennifer, please correct me, is it NYU Langone or Grossman School of Medicine?
That's correct, yes.
Okay. Specializing in neurocritical care and stroke. And Jennifer will present the incidence of neurological adverse events following vaccination against the new coronavirus, based on the analysis of the clinician and patient self-reported data in the CDC Vaccine Adverse Event Reporting System. Jennifer, the stage is yours.
Thanks. Just going to open my slides. Can you see my slides okay? Okay, great. Yes. So I'm going to discuss COVID vaccines and specifically adverse neurological events related to COVID vaccine. These are my disclosures. I'm participating in a few different NIH grants that are related to COVID and sit on the WHO Brain Health Task Force. So this is a dashboard that probably many folks have looked at before. This is the Johns Hopkins COVID dashboard. And so we have here basically COVID rates internationally, deaths, vaccinations, et cetera. And the numbers are large, but when you actually go through and kind of crunch them, it turns out that 1 in 30 people in the world has had COVID. That's 3% of the world's population, which is a shocking number. And 1 in 1,500 people in the world have died from COVID. The situation in the United States is not any better. In fact, it's worse. 1 in 8 US citizens has had COVID, and 1 in 500 Americans have died from COVID. So huge numbers, that are very concerning. When we look at vaccination, worldwide, about 55% of the US population is vaccinated, 2.5 billion vaccinated in the world, but that's only 32%. And we have these areas of kind of like Africa, for example, of low vaccination rates. And this is clearly a problem as variants develop, which may become resistant to vaccines. So these are the vaccine types that we currently have. And I'm highlighting the top 3, which are the ones that are available in the US, because I'm going to be talking about US data today.
Jane,
but so we have Pfizer, Moderna, and Johnson & Johnson. And
Jen, sorry to interrupt, but you are sharing your screen so that we see the next slide as well. Would it be possible that you, yes.
My apologies.
Okay.
Let me switch.
Thank you.
How's that?
Perfect.
Okay. Sorry about that. The mRNA vaccines basically are a new type of vaccine that has just been approved for the first time, at least in the US. And basically these are mRNA that enters the cytosol of the cell and then is translated into a protein which generates an immunological response. There are such things as DNA vaccines where DNA is administered that actually has to enter the nucleus, be translated into mRNA, and then later translated into a protein. Those are somewhat less effective. And then there's Johnson & Johnson, which is a replication incompetent adenovirus vector. The issue with adenovirus vector type vaccines is that if a person has had exposure to that particular vector in the past, the immunogenicity produced is going to be less robust than if they were naive to that vector. So companies try to choose vectors that are unusual, like for example, chimpanzee vector that most humans are not exposed to in order to maximize immunogenicity. But overall, the adenovirus vector vaccines are less efficient and less efficacious overall than the mRNA vaccines. A paper just came out in New England Journal last night about the Novavax vaccine, which is made from recombinant protein, highly effective. And then there's a variety of other vaccines that are available in Asia and China and Russia, for example, various levels of efficacy. Many of them are adenovirus vectors, but some are also inactivated virus vaccines. So I think it's probably important to mention some general adverse events that have been identified. So the CDC has pointed out a couple of things in the last few months. First, related to the mRNA type vaccines are an increased risk of myocarditis, and then with the adenovirus vaccines, increased risk of thrombosis, thrombocytopenia syndrome, otherwise known as VIT, and Guillain-Barré syndrome, which I'll touch on. So VIT, vaccine-induced immune thrombotic thrombocytopenia, or also called thrombosis with thrombocytopenia syndrome, has gotten a lot of attention, particularly in Europe, where AstraZeneca is more commonly used. I like the VIT acronym because it actually kind of reminds you of the symptoms: vaccine given, interval of 5 to 30 days from vaccination, thrombosis, and thrombocytopenia. And these patients can present with, I'm just showing you here, petechiae that's typical in this scenario. It's also been reported for the J&J vaccine, so adenovirus type vector vaccines. And basically, what's happening is the body's generating antibodies against platelet factor 4, very similar to what's seen in heparin-induced thrombocytopenia, but this is an autoimmune version of that. And this will present in a relatively interesting fashion. So venous and arterial thromboses and venous thromboses in atypical spots, such as cerebral vein thromboses or mesenteric vein thromboses. Often there'll be multiple thromboses at the same time. DIC is also often seen, which is unlike HIT, where DIC is not really seen. These patients are also prone to bleeding. The risk is about 3 per million doses for the J&J vaccine, perhaps a bit higher in women. And the thing to remember with VIT is that not only do you have to treat it with anticoagulation as you would with HIT, but there also needs to be an immunologic intervention with IVIG or plasmapheresis. Myocarditis has been reported at a slightly higher incidence with mRNA vaccines, so that's Pfizer and Moderna. This is just a cardiac MRI showing enhancement or bright signal in the myocardium. This is more frequent in younger males, and it's usually mild, fortunately. So people might present with chest pain, elevated troponin, but fulminant cardiac failure is uncommon. And these patients similarly can be treated with IVIG or plasmapheresis. Also, NSAIDs have been used, and steroids. In the VAERS data set, this seems to be a little bit more often reported after the second dose, with 827 cases and 267 after the first dose. But beyond these things that have been highlighted by the CDC, there's not been that much discussion or evaluation of neurologic adverse events. So what we decided to do as part of the subgroup of the WHO Brain Health Task Force is really to take a look at this thing that's called VAERS. It's the Vaccine Adverse Event Reporting System in the US. And this is basically publicly available data. So you can go and download these very large data sets of all these adverse events. It's very transparent. And it basically lists adverse events for all FDA-approved vaccines. So it's not specific to COVID, it has other vaccinations there. It's a passive reporting system. So that means that the events that are reported there are not verified, they're just collated. And it's meant to be sort of an early warning signal. So if there's a sort of higher incidence noted within the VAERS data set, then the CDC will go back and do a case-by-case investigation to really determine whether or not there is an actual signal there. So what we're showing does not say anything about causality. It's just showing the rates at which these events are reported. But this is still important because it gives us a general overall perspective on how common or not common these types of adverse events might be. So who reports into this system? So healthcare providers are required to report certain things. So serious adverse events that follow a vaccination within 21 days are supposed to be reported. So death, irrespective of whether or not you think it's causal, has to be reported. So perhaps someone is already dying of cancer, they get vaccination and then they die, that still has to be reported into the system. So a lot of what you're seeing is probably an overestimate of what's actually causally potentially related. Life-threatening adverse events, hospitalization, anything that causes disability to someone, birth defects, and then anything, adverse events that require medical or surgical intervention. MIS-C in children particularly has to be reported, breakthrough COVID infections, shoulder injuries, vasovagal syncope, and anytime a vaccine is given in contraindication to a manufacturer's insert has to be reported. So this is what's required. Healthcare providers are encouraged to just report any adverse event because we know so little about these vaccines, and administration errors are also supposed to be reported. The manufacturers of the vaccines also are supposed to put data into this same VAERS data set. They're required to enter all adverse events that occur and come to their attention. Beyond this, the lay public, anyone could go ahead and enter an adverse event. The website where you do report this, though, is very explicit, saying if you file a false report, this is a violation of federal law, could be punished by fine or imprisonment, to sort of discourage people from falsely reporting. If that's not enough, when you take a look at this form, you're going to lose your interest in falsely reporting anything because it's a little bit labor intensive. So this is just an example of the online form they want you to fill out. There's a lot of details. And frankly, when you look at the data, the raw data that comes out of this data set, it's very, there's a lot of medical language in it. So it appears that mostly this is really just being filled out by healthcare providers. So we decided to take a look at this data set. And I dumped the data on June 14th. And this is data reported from January 1st, 2021 through June 14th. It's important to know the timeframes because everything in VAERS is a moving target. So as data gets updated in real time, the values change. So the point of this really is to just take a snapshot about 6 months to get a general sense of what the incidence of adverse events are. So our numerator here are neurological symptoms, and we divided out 40 different neurological adverse events that were coded. So we had abstractors go through looking at the symptoms and the free text in a very labor-intensive fashion. This wasn't conducive to natural language processing type of thing. In fact, it appears that the CDC did some initial natural language processing on the free text that's entered on the form and then generated symptoms from this. When our abstractors went back and looked through the symptoms and the free text, they noticed that there was quite a bit more in the free text that had not come out in the natural language processing. So there's definitely limitations to that. Downside, of course, is that it's extremely labor intensive to go through 300,000 different entries and abstract the data, but we did do that. The denominator we're looking at is the total number of vaccines administered during that same time frame that we dumped the data. And this is also publicly available from the CDC, and it's broken apart by different vaccine type, namely J&J, Moderna, or Pfizer. So you can more specifically look at the impact of each vaccine separately. This is a list of the neurological events that we coded. It's relatively extensive and robust. And in fact, as abstractors started looking through the data, we added a couple of elements as well that came up. But you can see we're covering the typical things you might be concerned about after a vaccine: ADEM, transverse myelitis, other types of inflammatory disorders or encephalitises, Guillain-Barré, particularly because of the issues related to VIT. We're looking at hemorrhages and bleeds as well, including cerebral sinus thrombosis. Bell's palsy and some of the more typical things, as well as, confusion, tremor, blurred vision, and some general findings where headache, dizziness, syncope, etc. So during the time frame of interest here, there were over 306 million COVID vaccines administered. And in the VAERS data set for that time frame, there were 314,000 plus adverse events reported. And that's inclusive of neurologic adverse events, but also gastrointestinal, cardiac, other types of adverse events. If we look just at the neuro adverse events that we abstracted out, they comprised about 0.03% of all the vaccinations given. And keep in mind that the vast majority of these were headache, because there's some extremely mild adverse events that we put in there: headache, syncope, dizziness, etc. When we looked at the distribution among the different vaccines, so just as a reminder, during this time frame, the majority of people had gotten the Pfizer vaccine or Moderna, and a small fraction had gotten J&J because it was only approved for use in the beginning of March 2021. The adverse events reported, however, there was a higher proportion of J&J adverse events reported compared to the other two vaccines. This is a kind of a busy table, but it says the same thing. This is the total number of vaccines, the total number of side effects inclusive of any organ system, and then the neurologic side effects, which were overall significantly more often reported for J&J compared to Moderna or Pfizer, and significantly less reported for Pfizer percentage-wise compared to Moderna or J&J. The age of people reporting was lower for J&J, but keep in mind that the way the vaccines were rolled out in the US is that those over 65 were vaccinated first. So by the time J&J came to market in March, most of the older folks had already been vaccinated. And so it's not surprising there's a younger population that was vaccinated and also a younger population reporting adverse events. Overall, women tended to report more than men, although there's a significantly higher proportion of men reporting adverse events for J&J. Most often, these events were reported immediately after vaccination or within 1 day. And most of the events were reported after the first dose and a fewer percentage after the second dose for the mRNA vaccines. So this is a busy slide, and don't try to read all these things. This is just to give you an overview, and I'm going to break this down in a second, but these are all the events we looked at. And I actually had to truncate this because, to kind of blow up this lower stuff, because the J&J events were much higher for some of these very common things. And these are events per million vaccine doses. Overall, they're still uncommon in the grand scheme of things, but more common for J&J. And I'll just call out a few things that might be interesting that people are focused on, just to give you the sense of where these things occurred in the spectrum of other complications. So by far, the most commonly reported neuro event was headache, fatigue, dizziness, vertigo, syncope, which is typically vasovagal. But here's Bell's palsy. It happens. Ischemic stroke, TIA, Guillain-Barré, sinus thrombosis, transverse myelitis, and then ADEM here. So just in the spectrum of what is commonly reported. Just blowing up the left side of the screen. Again, same things. I did compare J&J to Pfizer and Moderna, so we compared them. So if you see a hashtag, that means that J&J was significantly higher than Pfizer, higher than Moderna, and in fact, Pfizer was significantly lower than Moderna. So you can see here, headache, fatigue, sleep disorders, confusion, ischemic stroke, anosmia, myopathy, all appear to be higher in J&J and lowest in Pfizer. Per what's reported. And the stars are just J&J being higher than Pfizer and Moderna. So for example, for dizziness, vertigo, syncope, tinnitus, vision abnormalities, Bell's palsy, seizure, movement disorders, and hearing loss. Again, and we'll talk about this later, but there's of course concern for reporting bias in any of this. The J&J vaccine had relatively bad press in the US because its efficacy was not as high as the mRNA vaccines. And so there might be a predisposition for people who do receive this vaccine to also report adverse events. For the very uncommon things, Guillain-Barré, I'm listing down here. At the time that I dumped this, the Guillain-Barré rate was about 5.25 per million doses for the J&J vaccine. Subsequently, CDC has put out a publication basically saying that the rate of Guillain-Barré was at least 5 times the background rate of Guillain-Barré for the J&J vaccine. And when they looked at data through July of 2021 and actually adjudicated the cases of Guillain-Barré, there were 20.2 per million cases for the J&J vaccine, so higher frequency than the background rate for Guillain-Barré. AstraZeneca has reported about a 4.5 per million dose rate. But again, this is a moving target. So when we looked at this through June, the rates were lower. And of course, we're just looking at various signal. We're not actually going back and doing a case-by-case analysis as the CDC has done. So this is one point here. Sinus thrombosis, was also significantly higher with J&J, but not higher than the background rate, which I'll show you shortly. Transverse myelitis and ADEM also occurred, but did not really differ significantly between different vaccine types, and were exceedingly rare overall. And so the take home is the yellow bar here is any COVID vaccine. So it's a composite of all three. And you can see that, overall, less than 1 million people who get vaccinated have any of the complications that are listed here. Looking at the median age, so this is older age over at this end of the spectrum, younger age here. It's sort of what you expect. So when people have subdural or stroke or intraparenchymal hemorrhage, they tend to be older patients. So not a surprise that this is also being reported. This is probably not causality, right? This is probably just the fact that these patients happen to have a vaccine around the time that they unfortunately also had an ischemic stroke or subdural. Myasthenia gravis, the second peak of prevalence for myasthenics is in older folks in their 60s to 80s. Could a vaccine trigger a myasthenic crisis or a worsening of myasthenia? Is possible, but again, the causality has not been shown, and there are very few cases of myasthenia that have been reported following vaccination. On the other end of the spectrum, younger folks are what you would expect. So ADEM is much more common in children and young adults, as are other demyelination syndromes. And then vasovagal syncope tends to happen more frequently in younger folks as well. Seizure is down here. I'll just point this out that, I don't know, maybe some of the seizure events are actually convulsive syncope. So we have to sort of be careful in our interpretations of these things. When we look at gender, again, women were more likely to report adverse events than men. This may be just a form of reporting bias, but there are certain things that are more common in women. So subarachnoid hemorrhage, we know, is more common in women. Cerebral vein thrombosis, also more common in women. So some of these are expected. When we look at timing from vaccine dose to symptoms, the things that are post infectious, autoimmune mediated, for example, encephalitis, NND encephalitis, cerebral vein thrombosis. I put that here because VIT is a frequent cause of this, and that is basically an autoimmune phenomenon. Guillain-Barré, ADEM, transverse myelitis, etc. They're happening in a delayed fashion, as you would expect for these types of disease processes. So presenting 5 to 7 days after vaccination. And then things like confusion and syncope are happening at the moment of vaccination, which sort of suggests much more of a vasovagal type of phenomenon. Most events were reported after the first dose and fewer after the second dose. But overall, context matters. So when we're talking about these event rates, we have to keep in mind, first of all, the background event rates, but then also the risks of COVID that are occurring at this moment. So background disease rates, if you just pull up some of this data, so stroke, 795,000 per year in the US, so 0.24% of the population annually will have a stroke in the US, versus in the VAERS data set, it's 400 times less common after a vaccine. So this is not a signal. This is just what we're seeing is true and unrelated, just a casual relationship. Transverse myelitis, similarly, the background rate is higher than what we're seeing post-vaccination. For Guillain-Barré, in the numbers that we ran, it looks like the background rate is higher than the post-vaccination rate for J&J. However, that's why we have the CDC. They go and dig down into individual cases. And it does look like for J&J, particularly the rate of Guillain-Barré is higher than the background population rate. So there may be a true risk there. Cerebral vein thrombosis, also lower than the background rate for J&J. And this has not been found to be a specific risk, though VIT itself is at a higher risk for the adenovirus vectors. Bell's palsy, I think Raimund mentioned this also, the rate with Bell's palsy is substantially lower than the background rate in the population. So again, true and unrelated. Similarly for ADEM. In terms of COVID, you got to remember that you are 1,000 times more likely to die from COVID than from a COVID vaccine. And frankly, these deaths that are reported here are required by law. Most of them have absolutely nothing to do with the vaccine whatsoever, but much smaller than what your risk is with COVID itself. And I do want to just say that, during the surge in New York City, 1 in 5 people hospitalized with COVID died. And that was because of the stress on the medical system that couldn't really handle it. So your chances, if we get into a crisis situation again, of dying from COVID are extremely high. The thrombosis rates in critically ill, non-critically ill people is substantially higher than your chance of having VIT from any of these vaccines. It's also been reported in Moderna, by the way, but still substantially higher than for the adenovirus vectors. Myocarditis, still much more common in the general population than with a vaccine. And so overall, your best bet is really to get vaccinated. When we look at neurocomplications compared to what happens with COVID, and this is just sort of a compilation of data from different studies, your chance of having any neuro event, and Raimund sort of pointed out that there's a big spectrum, anywhere from 14 to 80%. The 14% comes from our study, which was prospective, so a more conservative kind of estimate, and then 0.03% compared to post-vaccination. So any of these different complications that I'm listing here, though some of them are quite still uncommon with COVID. We saw 3 Guillain-Barré cases, so 0.1% of hospitalized patients, are much, much less common with vaccination than with COVID itself. Here is a paper from the Israeli group. They looked at the Pfizer vaccine. This was published in New England Journal a little while back. They matched vaccinated patients to unvaccinated patients without any of these history of these prior complications, and there was 888,000 patients in each group. What they did see, so this blue line here is the risk ratio for the vaccination, and the yellow is risk ratio with COVID or SARS-CoV-2 infection. And the things that were slightly more common with the vaccination were myocarditis, lymphadenopathy, herpes zoster, and for whatever reason, appendicitis. But if you look at intracranial hemorrhage, DVT, PE, again, rates are substantially lower post-vaccination compared to post-COVID. And here's a few more events that they published in this paper. So Bell's palsy, no significant difference, stroke, intracranial hemorrhage, paresthesias, seizure, syncope, vertigo. None of these are significantly different between vaccinated and unvaccinated groups, or vaccinated groups of patients versus control population. So some limitations of our data, important to point out, we're not looking at causality, just signal. And overall, the take-home message is that these complications are extremely unlikely. Recall bias is an issue, so reporting bias as well. So patients with J&J might over-report because of bad press related to that vaccine. Diagnostic error can come into play. So what's written in the record comes from a variety of different people: nurses, doctors, NPs, PAs, lay patients. And so if they write that they had a diagnosis of myasthenia gravis, it may or may not be true. We can't really verify it. There's recording error, and then of course inter-rater variability, because we had a lot of different abstractors looking at the data and recoding it. But at the end of the day, I think we can safely say neurological events are extremely rare, less common than neurological events that happen after COVID itself. And they seem to be less common than what's just basically happening in the background without vaccination or COVID. Headache, fatigue, dizziness, vertigo, and syncope were most commonly reported, not unexpected reactions to vaccination. The more serious stuff that we are concerned about, Guillain-Barré, ADEM, transverse myelitis, sinus thrombosis, myasthenic crisis, et cetera, occurred in less than 1 per million vaccine doses. There were more adverse events reported for J&J, more adverse events reported in women or by women. Vast majority of the events happened within 24 hours of injection, and the majority were reported after the first vaccine dose. But at the end of the day, the point is get vaccinated. This may not be controversial in Europe. Unfortunately, it's political and controversial in the US. And I hope we can kind of move beyond that, frankly. I do want to thank all of our collaborators. These are all of the people that really helped abstract this data. It was a heavy lift, and many thanks to Mara and her group as well, who did help with this. And so I will stop here, and I'm happy to entertain any questions.
Thank you very much, Jen. Unfortunately, we are really pressed for time. There are questions. Maybe if I can allow myself just one, so that it signals at least our complete willingness to open up this for the discussion. However, I will then ask you to please hang on just a bit. I'll forward the rest of the questions and kindly ask you to answer them in writing. So the idea that I think is quite interesting for many is there any method that can be used to test for a person's likelihood to develop side effects ahead of time, so that maybe, we can select those who really can safely be vaccinated, if I understood the question correctly.
So I think really the only recommendations are basically for people who might be at higher risk for VIT. So folks that have middle-aged women, basically, or who are already hypercoagulable should probably avoid adenovirus vector vaccines and try to go for mRNA vaccines. Aside from that, and then, for people who've had a history of Guillain-Barré, for example, the suggestion is to also perhaps try mRNA vaccines rather than adenovirus vector vaccines. But people who've had a history of Guillain-Barré still should be vaccinated. That is still the recommendation. Same for multiple sclerosis and other diseases. If you're on a disease-modifying drug for multiple sclerosis or immunologic, that has to be managed and timed appropriately, and doses changed when you do go to get a vaccination. So there are extensive guidelines on how to handle that in populations that are on immunologic medications.
Thank you very much. The rest I will forward to you immediately. And now we need to move on with the next speaker. So our next talk departs from the hardcore neuroscientific content and actually opens up our minds to the wider context of what the pandemic has done to our brains in terms of the potential educational consequences of the pandemic and the inequalities in that process across Europe. And I welcome our next speaker. Zsuzsa Blaskó is at the Joint Research Center of the European Commission. Her main research areas include educational inequalities, poverty, gender relations, and in her talk she will give us an overview of the existing research regarding the magnitude of COVID-19 related learning losses in Europe, along with a contribution of socioeconomic differences. Zsuzsa, the stage is yours.
Thank you, Maja, and thank you, everyone. I have to admit that I am a bit nervous. First time ever I am presenting to scientists. I am very much used to presenting my work to policymakers and in the academia to social scientists, but I really hope that there will be interest for what I can tell to you, even though it's really different from what I have heard so far. I want to share my screen, which means that I need to stop others' screen sharing. Sorry, just a second. Okay. Right. I assume that you can see my screen now.
We can, thank you.
Yeah, great. So yes, as it was mentioned in the introduction, our work was, the work I will report about is looking at the potential learning effect of the COVID-19 crisis. I think it's really clear that for those in the medical and in healthcare, life has changed massively due to the COVID-19, and your research has been research focus has been reoriented. But you can imagine that this is similar for some of us also in the social sciences. So definitely we started from the very beginning of this crisis trying to understand what we can expect to happen in the different social dimensions that were really badly hit by the crisis. I will tell you about the piece of research that we did with colleagues at the Joint Research Center, but first I would like you to have a look at some of the background, at the motivation of the work we are doing. And just a second, because my screen wouldn't move, even though I'm trying to move forward. This worked in the pre-section, but it doesn't seem to work. Okay, yes, here I am. Good. So as you know very well, the crisis led to a major disruption in education, an unprecedented one in fact. And on this graph, what you can see is the number of weeks when schools were closed in the different European countries. The the picture would be even more worrying if we would go beyond Europe, but our focus was Europe and mostly the member states in this study. So what you can see is the lighter bars, the longer ones, show you the number of weeks when in a country either all the schools for primary and secondary school age students were closed, or a partial school closure was taking place, meaning that either certain regions or certain grades, certain sections of the schools were physically closed. Quite worryingly, you can see, well, this data covers the first wave of the COVID plus the previous academic year, so it goes up to July 21. And during this time, in several European countries, the number of weeks when at least a massive part of the students could not attend school physically reached 40 weeks or more. This was the case actually also in Slovenia, but also Slovakia, Czechia belongs to this group. But also if we take the more strict measures, which is the full countrywide school closure, we find some countries in critical situation, like also Poland, Bulgaria, Hungary belong to those where 20 or more than 20 weeks were spent without proper face-to-face schooling of the children. So why is this a problem? There are many answers to this, but we will focus, or I will focus today on what is called learning loss in the literature. So from the beginning, there was a very strong assumption that distance learning will not properly replace face-to-face learning, and it will be less efficient than as if the school would have continued normally. So from the start, relying on pre-COVID research evidence as well as some theories, we all assume that a learning loss will take place practically everywhere where schools had to be closed down. First, it was clear that an abrupt change to distance learning will not result in an efficient enough distance learning system. So there is no way the same amount of academic progress can be achieved in this method. The question is simply how much is being lost in the different situations. Also, we know from pre-COVID studies on different school disruptions, such as summer vacations or teacher strikes, that when there is no teaching taking place, then the student achievement reduces. And it's also shown that it's not simply that there is no progress being made, but children actually even forget some of the content they knew before. Even more importantly, and this is of major concern, this learning loss is not equally distributed across the different student groups, and it is the socially disadvantaged groups that lose out more when there is no schooling, when they cannot attend school. Also, another stream of studies shows that additional instruction time is more beneficial for the lower socioeconomic background children, meaning that if you compare the different countries where for the same age group, different number of learning lessons are provided in a given amount of time, then you find that there is more achievement associated with a higher number of lessons delivered, and this advantage or this additional benefit is higher for those that come from lower status families. So basically, the explanation behind this phenomenon is that in lower socioeconomic status families, they cannot provide an environment that is equally promoting cognitive progress as in other settings. The way we measure socioeconomic background is through the parents' educational level, occupation, or income. But beyond that, it has also been shown that certain characteristics of the home environment, such as having books in the home, getting actual parental support, having technical equipment available, they all provide additional help to the children to improve. And it is also assumed that these become even more important when the amount of schooling time is reduced and more time is being spent at home, and actual help is needed from the parents to support distance learning. And finally, in certain countries, still the level of school segregation is also expected to contribute to this process, because in many places, lower socioeconomic children don't attend same quality schools as other children do. So there is a fear that they also lose out during the pandemic, simply because not all schools can provide equally high level of distance teaching. So these were all the knowledge we had before the crisis, and on the basis of which already the early predictions were rather pessimistic. Here I give you a list of some of the major early assessments of what is likely to happen. So the World Bank, the JRC, where I work, and also the OECD has published different calculations. I only want to refer to the OECD one here, because that also gives you an idea about the real significance and long-term importance of these concerns. So there, Hanushek and Westman calculated that the different scenarios exist, and one of them, which is not the most pessimistic one, suggests that students of today, that in grades 1 to 12 that are affected by these closures might expect something like 3% lower income over their entire lifetimes, unless some very efficient and successful interventions are put in place. So really the risk is large for the group affected and for the entire economy and societies in the future. And all the experts agree that, as I mentioned before, this loss will be bigger for those that are already in a worse situation due to their socioeconomic background. So in the end, what we expect is a massive increase in the educational inequalities, which we know is related to income inequalities. So basically, they will form our societies in the future for quite a long time. So this was the predictions. In the lower part of this screen of this slide, I give you some examples. There are not many, where researchers had the possibility to actually measure the loss that was experienced. Maybe the most important one comes from the Netherlands, because it relies on very good data. And in the Netherlands, where they only had at the time 8 weeks of school closure, and which is a quite advanced country, even in a European comparison, as you know, in terms of technological preparedness of schools and so on, quite a massive loss was found. In fact, what they found that after 8 weeks, students achieved, so the kind of loss they found more or less equal to the amount of improvement you would expect during the same amount of time. So on average, these kids just didn't progress at all while studying at home. Of course, the variation was huge, and as expected, low socioeconomic background children lost out more than the rest. So I will just quickly mention what I put on this slide. This comes from online surveys that were carried out during the pandemic in different countries. Again, no causality here, but they give some very interesting, important pieces of evidence about the learning experience of children in the different social groups. So now we have evidence, for example, from some countries that indeed educated parents spent more time helping their children with their home-based learning than parents with lower education did. So there are various channels through which this inequality that we expected might have indeed operated during the lockdowns. Variations across countries, difficult to compare, but at least some pieces of the puzzle are already there to understand a bit what was going on. So this is more or less the background to which we did our research. Well, not quite true, because we started this before many of these new evidence were out. And basically, our idea was that we realized that it will take quite a long time to get new reliable data across the countries on what was actually happening. So, because for many reasons, but this is one type of data that is difficult to collect, and obviously the COVID doesn't help to carry out large-scale international data collections, particularly in schools. So we decided that we still rely on pre-COVID data. So this is the paper I will tell you about. We wrote this together with 2 colleagues, Patricia da Costa and Silke Schnepf. And what we did, we took the trends in international math and science study from 2019. So this is indeed the most up-to-date, large-scale international student assessment data before the COVID. If you are not familiar with this data set, you might think of the PISA data. In a way, TIMSS is similar. So it assesses students' knowledge in mathematics, but it does so in a younger age group. So it's fourth graders, 10-year-old children that I will speak about. And it covers somewhat less countries than PISA does, but it has 22 European countries which we could look at and could compare. What I will show you is kind of simple descriptive statistics and regression analysis, and we use quite a bit of logical deductions to make conclusions and to try to answer our main research questions regarding the relative size of the learning loss in the different countries, and whether or not and to what extent we can expect the educational inequalities to increase in the different European countries. So let's start with the first question I just mentioned. So which European countries have a high risk of suffering a particularly big learning loss? This is how we speculated. Well, obviously, the longer the school closure, the higher the possible loss. And we considered two very important set of resources that is needed for an efficient distance learning. One set is the home resources that the children have. So as you will see, we identify the various factors that in the home might affect how well the children can follow distance teaching. So we argue that the more children are lacking these, the most likely it is that overall in the country a big learning loss will be experienced. And at the same time, we also try to measure to some extent the technical preparedness of the schools, so to see how prepared they were to switch to distance teaching. Before showing you our data, I want to give you an overview of all the European countries. This is mainly because we don't have the Netherlands in the TIMSS data, unfortunately. I still wanted to show you that the quite varying estimate I mentioned before comes from a country so the Netherlands, which is marked with color green here, which was really in a relatively very good position in this crisis. So on the x-axis, you see the percentage of students who attended a so-called technically less equipped school. So the more on the right-hand side you see a country, the less the schools are equipped with ICT, different ICT tools. So clearly Netherlands is towards the left end of the scale. And at the same time, they were also lucky, or they did well. It's not for me to say it, but anyway, they didn't have so many weeks when all the schools were closed down. So in the end, their estimate of the learning loss is something like a best case scenario. There is a worry that in other countries, the situation might have been much worse. So let's now move on to what we can see from the TIMSS data we used. So as I mentioned, we measured school resources with two characteristics. So there is a headmaster questionnaire attached to this TIMSS data set, so from which we could tell whether in a school there was an online learning management system or not, or if the headmaster reported that they have no access to good digital resources. So this we used as a measure of school resources. We have more indicators for the household resources, home resources, we call them. So the proportion of children that had no internet in their homes varied between 1% and 14%. And then you see we also take into account whether they had a room, whether there are books in the home or not, whether they are regularly hungry in the mornings. And we also have a proxy for limited parental support. Putting all these together, we created one combined index, and this is what you see on the x-axis this time. The further right, you see a country on this index, the more children were in a bad situation, relatively speaking at least, to have good access to distance teaching. On the other axis, you see the mass achievement of the country. So basically what we wanted to see here, whether there is any kind of correlation between the likelihood of losing out a lot and having average mathematics achievement of children in a country. So as you see, there is some negative correlation here, suggesting that unfortunately exactly those countries are likely to lose out the most that already didn't do very well before the pandemic. So our prediction is that educational inequalities between the countries will grow within Europe as a consequence of the crisis. So let me now move on to within country inequalities. Here, as I said, any assumption would say that yes, indeed, they will increase, but we wanted to see whether there are some countries in Europe with bigger risks to this consequence. Again, we argued, of course, that the longer the school closure, the higher the risk, the more children are lacking the important resources and school resources, the higher the risk. But we also took into account how much the parental background as well as the access to the home resources mattered in terms of educational outcomes before the crisis. So in other words, we assumed that the stronger the association between the child's social background and home setting was already before the crisis, the bigger is the problem, because it is exactly these characteristics of the home that might make the online learning less efficient. So if they already started being worse off before the pandemic, then most likely they will lose out even more as a consequence. This is just a quick overview which links mathematics achievement to parental education only. So you see that in each and every European country, this is not a big surprise. There is a strong, significant association between the children's mathematical achievement and parents' education, but the variations are massive, with many Northern European countries on the left-hand side, and Bulgaria, Hungary, France, and so on the right-hand side. But let's move on, because this is more interesting. So this only gives you the pooled data results, so Europe as a whole. On the average in Europe, there is a 48-point difference in the math achievement score between a student with parents with higher education and a student that doesn't have a parent with a higher education level. However, beyond this, and this is what you see on the right-hand side, other factors also matter. So it's even worse if there is no internet at home, even worse if there is no book at home, and so on. So all these disadvantages accumulate, and indeed those children that have the most difficulty to follow distance teaching during the pandemic were already massively lagging behind before the pandemic started. This is the main message from this graph. So let's move to the last graph, which is kind of trying to bring together all the information I was showing you before. So again, on the x-axis, you have this lack of resources indicator with the countries where many children were in a difficult position to follow distance teaching due to not having access to very important tools and means. These countries are on the right-hand side. And at the same time, on the left-hand side, you see how big the socioeconomic differences were already before the crisis. So basically, we argue that where not having these resources matter, and many children are not having them, there the problem is really big, because it means that they already had low mathematical and probably also other achievements before the crisis. They started already as low achievers, and then they found themselves in a situation where they were really lacking support from their home background and possibly also from their schools to follow efficient online learning. So basically, countries in the worst situation in this regard are in the bottom right-hand side, bottom corner. you see Bulgaria, Germany, Slovakia, and Spain here. And the countries where the concern can be the least are on the in the opposite corner, in the top on the left-hand side. What we also indicated here is countries, and they are marked with color red. These are countries where there was an above average, where the length of countrywide school closure was above average. So, which we said is an additional factor to increase the risk. So very clearly, Bulgaria is in a particularly difficult situation across all the countries, across any measures that we use. But I would say that also Malta, Hungary, and the Czech Republic are at big risk of increasing educational inequalities that were already not little before the crisis. And at this point, I also would like to mention one important limitation of our study, which is the fact that we don't have all the European countries. So it is really just the relative position of the countries that you see here. And if I would now go back, which I will not do, to an early graph and show you again, for example, the position of Romania, where we saw many poorly equipped schools from a different data set, and where also the length of school closures was quite significant, then we might wonder if we would find also Romania, for example, in this bottom right corner. So this is definitely not the full picture, but this is one first strong attempt to have an idea of the relative position, what the different countries can expect as a consequence of the crisis. So to conclude, as I said, we are pretty sure that the overall learning loss will be the biggest in the countries where schools were closed down for a long period of time and where both children and schools were badly equipped for distance teaching and distance learning. We argue that this is particularly worrying in those countries that already were low achievers before the crisis. This is a problem in itself, for example, in Bulgaria, but to a lesser extent also in Poland, Malta, and Hungary. But looking at the overall European picture, this also tells us that we can expect the inequalities between the countries to grow. Which is something that definitely is a concern at the European level. Within the countries, also our argument clearly shows that we expect a significant increase in the educational inequalities within the countries. Again, the biggest one in countries with long school closures and poor resources. And we also argue that it is particularly worrying if those children that are not having enough resources to follow the distance learning were already low achievers before the crisis started. And again, following our analysis, you can point at the countries where this is the case and where the situation is particularly worrying. Also because, you know, it is the countries where social inequalities in education were high before the pandemic. They are also countries where there are some very important systematic reasons for this, which are not easy to change. And there are structural reasons why they are not very good at handling these inequalities. And it will be a real challenge for them to change this situation after the COVID-19, or not after. In fact, what I'm talking here now is actions and interventions needed today and yesterday already. So we cannot talk about after COVID-19 interventions here. We are in the COVID-19 still, and we already have to be very, very, very active in intervening into all these negative processes that I just described to you. So this is the major policy message, I would say, from the analysis, but for sure there are other aspects that we could discuss. So I'm looking forward to hearing your questions. Thank you very much.
Thank you very much, Zsuzsa. It was, as expected, a very sobering view of the other ways in which our brains are under attack by the pandemic. I really appreciate your contribution. There are some questions I guess we are really pressed for time, so I would ask you just one, and then kindly ask you to answer a few more in writing. So the one that I got first is whether, in your opinion, the rights to internet connection should become one of the basic human rights sometime in the future.
I have to admit that I am not very familiar of how you decide what becomes, and it's a very complicated political procedure, how something becomes a basic human right. But yes, so definitely access to internet will be it is a basic resource increasingly, and not having it really means losing out on so many sides of the society and an economics life, that this is something that we should aim for.
Yeah, we live under very rapidly changing times, and we need to keep up with the pace. Thank you very much again. We need to move on.
Thank you.
To the next speaker. It is my great pleasure to announce a repeat visitor and invited speaker at the Synapsa Neuroscience Conference. Professor Adrian Owen comes from the Brain and Mind Institute at the Western University, Ontario, in Canada. He is the former Canada Excellence Research Chair in Cognitive Neuroscience and Imaging. And in his talk, he will present the results of a global online longitudinal study of the short and long-term cognitive sequelae of COVID-19 infection that had been launched in his laboratory in June 2020. Adrian, please.
Thanks very much. And thanks for the introduction. As you know, it's been 12 years since I was able to visit you guys in Ljubljana, and I was really hoping I could come back again this year, but maybe, who knows, if things continue to improve, perhaps this year or the year after, I'll be able to revisit. So you've already heard from Professor Helbok an excellent overview of the neurological consequences of COVID-19. So actually, I'm going to focus primarily on the cognitive sequelae, but let me just give you, let me just share my screen and give you a very brief introduction. How's that? Can you see my screen?
Yes.
Okay, great. So as you've already seen from Professor Helbok, the neurological sequelae of COVID-19 are very well documented now. People report with headaches, aches and pains. I guess the canonical symptom that most people in the general public will be familiar with is loss of smell and taste, but also things like blurred vision, strokes, in very, very bad cases, seizures and delirium also occur. But as I said, what I am really interested in is impaired cognition, the possibility of both short and long-term cognitive impairments following COVID-19 infection. And out there in the world, this is often referred to as brain fog. And I completely agree with Professor Helbok that this is not a very useful term. It doesn't mean anything to neuroscientists or psychologists, really. But it's interesting that it's out there in the world, and it's the way that people describe their symptoms. And one of the aims of our study was to try and understand, well, what are people really talking about? What is brain fog? What are the underlying cognitive and neuroanatomical substrates of this condition that is often referred to using this term? Now, as you've already seen, cognitive effects could occur due to either direct or indirect effects on the brain. And you've already seen some data which suggests, and I think this is probably where the consensus is now, and that is that in some people, there are direct neuronal effects of COVID-19. It's probably not universal. It's probably not what's happening with everybody. And there I think we need to look at indirect effects. Indirect include things like inflammation, both central and peripheral, blood clots, and various versions of low oxygen levels. I mean, this is ostensibly a respiratory disease, and respiratory diseases interrupt the oxygen supply to the brain, and that, of course, can lead to certain types of brain injuries. So, low oxygen levels caused by being on sedation, for example, being under sedation, being on a ventilator, and just being in the ICU. In 2019, my group here in Canada published a study of 20 participants who all left the ICU or all were in the ICU for non-brain injured reasons. But it turned out that when they left the ICU, all of these participants had ongoing cognitive impairments. Now, we don't know exactly why that is, but a combination of, being sedated, some of the anesthetic agents that are used in the course of ventilation can have effects on the brain, lack of sleep, and other things that happen to people in the ICU, I think, can all contribute to potentially contribute to long and short-term cognitive sequelae. Now, here's the problem, and this is what this slide. Every time I give this talk, this slide changes. In fact, between writing the abstract for this meeting and giving this talk, that first number, 230 million, went from 160 million to 230 million. That's how quickly things are expanding. But so there are more than 230 million people in the world with COVID-19 or have had COVID-19, and that's 43 million in the United States alone. And the problem that we faced when we set about our study actually over a year ago now was that, we realized that a year from then and now, we may have upwards of 230 million survivors who are all experiencing cognitive problems that affect their jobs and their ability to go about their daily activities. And this is an enormous economic and societal problem. And if, this problem has been big enough as it is. The pandemic itself has caused an enormous economic and societal problem, but this is potentially, if we don't get on top of this, something that could rumble on for many, many years to come. So we started looking at this very early, back in May and June of last year. Fortunately, over the last 25 years or so, I've developed a cognitive assessment platform in my lab. It's called Cambridge Brain Sciences. They're all short tasks that measure aspects of cognition like working memory, reasoning, planning, problem solving, decision making, these sorts of things. Now, in many ways, I consider that I was extremely lucky in that this platform was all up and ready to go. And of course, in a pandemic involving a contagious virus, very few of us want to sit down and do face-to-face cognitive testing. But also, we were really interested, and having online cognitive assessments answers that problem. But also, we were really interested in the sort of international perspective. We wanted to try and get as many participants as we possibly could internationally to join the study, tell us about their experiences, fill in a lot of questionnaires about their medical history, and then take the cognitive tests over a year's time. We started immediately that people had recovered from the immediate infection, then tested them again at 3 months, and then again at 12 months. I can only give you the early data now, but I'll make a few comments about the longitudinal piece, what we know about that. I won't give you any more details about Cambridge Brain Sciences. The tests are all short. They've been published in many, many papers over the years. We have a very large normative database of over 75,000 participants who've given us a lot of information about themselves and completed the tests on a number of occasions. For those of you that are not familiar with Cambridge Brain Sciences, here's a brief. Here's one of the tests. Here's how it works. It's called our odd one out test. You simply, of these 9 shapes, have to identify the odd one out. You can see this person performing the task. It's pretty easy. The odd one out is just the one that's a different color. Don't get too excited. This is a really easy problem. And like all of our tests, they very quickly get harder as you do well, and they'll get easier if you perform poorly. And that's the way that we very quickly managed to iterate towards somebody's actual level of performance. So this is a test of reasoning ability. It's based on classic neuropsychological tests of odd one out tests that assess reasoning ability. But there are another 11 tests that in terms of the format, they look very similar to what you've just seen. So we set up a website. We had some media partnership to try and get some publicity. And basically, we encouraged anybody who had COVID-19 to come to the website to fill in quite a lengthy questionnaire about the experiences that they'd had, their medical history, their lifestyle choices, whether they smoke, whether they drank, these sort of things, and also to complete the 12 cognitive tests. And they had to sign up longitudinally to contribute every few months for a year. Now, of course, as we'd hoped, we got many, many thousands of participants that initially responded, but very quickly it became clear that we had a little bit of a problem. And that is, how do we determine exactly who has had COVID-19 from those people who maybe think they've had COVID-19 but had another condition. So despite the fact that we started with a very large cohort, we decided that we would focus on those participants who had actually tested positive, that had a formal medically confirmed positive test of COVID-19. And of course, we started this study back in June of last year, when really there was hardly any testing going on. So the number of patients I'm going to report on today is about 500. These are all 500 patients who have all had medically confirmed a COVID-19 diagnosis, and they are all in the recovery period, and of course at various stages of that period. And here's some of the questions that we set out to address. Now, does COVID-19 infection result in significant cognitive impairment? Okay, that's the big question. Does brain fog actually exist? And if so, this is the secondary question, what cognitive domains are most affected? What is brain fog? Is it an attentional problem, or a memory problem, or a reasoning problem, or whatever? What about the severity of COVID-19? Is the burden of cognitive impairment greater in those who require an ICU stay? Because this can give us some clues about why these participants are getting cognitive impairments, if indeed they are. So, do those who are hospitalized, are they worse, for example, than asymptomatic patients? What about at extreme levels? Is this something that only occurs in those participants who are ventilated or sedated? Well, any Google search will suggest to you that that is not the case, because there are people who are even fairly asymptomatic that have reported cognitive deficits. But of course, we cannot rely on subjective reports of the general population. We have to test this carefully and scientifically in the lab. Now, what about the longitudinal piece? Again, I can't tell you much about that because we don't have the 1 year data fully analyzed yet, but I can give you a few clues about what I think is going to go on. And other interactions with things like sex, age, medical risk factors that result in greater impairment, greater impact in some populations. So here's our population. As I say, it's about 500 individuals. And what we did is we divided them up according to the World Health Organization categorization. And that is, you get a 0 if you have no symptoms at all. But of course, they've all been medically confirmed COVID-19, up to a 6 if you're in the hospital, you're in the ICU, and you are on ventilation. That's about as bad as things could possibly get. On the right-hand side, if you look at the histogram, I don't think anybody will be particularly surprised that most of our participants were in that middle range. We didn't get a lot of people who'd been in the ICU on ventilation responding, although we had 15. But we had a lot of people around the 1s and 2s, the symptomatic, affecting daily routine, but probably managing to stay out of hospital. So let's look first at the subjective data, because one of the things we did, as I said, we had a very extensive questionnaire about sort of medical health and the experiences that people had had. But we also asked them what they thought might be wrong with them. Did they think they had memory impairments? And this was just a simple couple of questions. Do you think your memory was impaired by COVID-19, and do you think your memory is back to where it was prior to COVID-19 infection? As you can see, there is a lovely relationship between the severity of COVID-19 infections. So that's the World Health Organization index from a 0 to 6, and how people rated their subjective memory. Now, look carefully at this. I mean, those people who are asymptomatic are still not saying it's excellent. They're still not saying it's back to where it was. Even asymptomatic people are reporting some sense that their memory is not as good as it used to be. Of course, nothing like those people at the other end of the scale who are hospitalized or in the ICU who report having very poor memories relative to before the pandemic. We also used formal assessments of anxiety and depression. Again, people had to contribute quite a lot of time to be in this study. They had to fill in anxiety questionnaires, depression questionnaires, all the cognitive tests, and lots of questions about their medical history. But it meant that we were able to look at the mental health risks, anxiety and depression. And again, both of them, or at least, this is people's personal interpretation. People personally reported. I'll come to the objective data in a moment. Subjectively, people reported having high levels of depression and anxiety, and again, this was related to the severity of COVID-19 infections. Now let's get to the really important stuff. This is what I really want to tell you about today, and this is the outcome of, this is the objective data, the outcome of the questionnaire data, the depression, anxiety scores, and the cognitive assessments. Now, when we put all of the data into a factor analysis, what we found is that two factors came out. This is quite a complicated figure you're looking at here, but let me explain. There are two rings, and the two rings represent the two factors. The darker the color in the ring, it doesn't matter whether it's blue or pink, but the darker the color represents the loading of any given score on that factor. So the inner ring there, we're going to generally refer to as physical symptoms, because it refers to how people rated their things that loaded heavily on that factor, or how people rated their physical functioning, how they rated their physical limitations, whether they said they were fatigued or in pain. And between the rings, the lines that you see between the rings, the thickness of those lines tell you the strength of the connections between different scores that contribute to that factor. So you won't be surprised to know that how people rated their physical functioning was rather strongly related to how much pain they reported being and how much fatigue they had, but it wasn't at all related to whether they were depressed or whether they were anxious. So that's our physical factor. But there was a second factor that came out of this analysis, and that we now refer to as mental health symptoms, because the strongest scores, or the scores that contributed most to that factor, were scores of depression and anxiety. This is the outer ring you're looking at here. And of course, these loaded quite strongly with things like how people rated their emotional limitations, but it didn't, as I've said already, it didn't relate at all to their physical symptoms. Now, why is this important? Well, it's really because we believe there actually are two dissociable outcomes from COVID-19 infection. One are predominantly physical symptoms, and one are predominantly mental health symptoms. Now, that doesn't mean that any one individual will have one or the other. You could well have both, you could well have neither, but they are dissociable, which probably means that they have different neuroanatomical or neuropathological substrates. Now, how do we know they're dissociable? There's many reasons why we know that, and I can point you to a preprint of the paper if you want the details. But here's a simplest example I can give you. That if you factor in age, if you look at how age relates to physical and mental health symptoms, you can see the nature of this dissociation. And that is that the older you are, the more severe your physical symptoms are likely to be. Nobody's going to be terribly surprised by that result. What is surprising, though, is that the younger you are, the more severe your mental health symptoms tend to be. So these two factors go in opposite directions as they relate to age. Older people tend to have more physical symptoms, but tend to have fewer mental health symptoms, whereas the reverse is true in the younger population. For them, it's the mental health aspects, anxiety and depression, that are affecting them most. But most importantly, I want to tell you now, in my final couple of slides, how this relates to the cognitive deficits. Again, these were not measured using a sort of generic scale like the mini-mental state or the MoCA. These were measured with 12 cognitive tasks that are designed to pull out specific specific, generally executive processes like working memory, reasoning, decision-making, and so on and so forth. To make things simple, I am going to cluster these around 3 factors. We've done a lot of work on these cognitive tests, and we know that performance can best be described in terms of 3 factors that one might refer to as short-term memory, reasoning, and verbal abilities. We also extracted measures of processing speed, because a lot of people report that they just think more slowly than they used to, and of course an overall measure of cognition. And one of the main findings was that these things are not all equally impaired. Brain fog is not a generic thing. It turns out that people's short-term memory was really not impaired at all. It was extremely resilient to COVID-19 infection. Nevertheless, reasoning, verbal abilities, processing speed, and as a result, overall cognition were significantly impaired by COVID-19 infection relative to a control group, a large control group of participants that I haven't actually mentioned yet, who had not been exposed to the COVID-19 virus. So that starts to tell us a little bit about what brain fog is. What are people talking about? And it's not a memory problem. People are not forgetting things. They're having a problem making decisions, reasoning, thinking through problems, and slowed thinking. I think that's very important. The second important thing is, how do these symptoms relate to the 2 factors that best describe their overall physical and mental health? And again, there are a couple of surprises here. The main one is that these cognitive deficits load heavily on the same factor as physical symptoms. So how physically ill you are will determine the extent to which you suffer from these cognitive sequelae. The mental health symptoms are completely unrelated to the cognitive sequelae. And again, I think that's going to be quite surprising for people, because we know that depression and anxiety outside of pandemic times are often associated with cognitive impairments, and one might assume that the same thing would happen here. But of course, this is a very difficult situation, very different situation. And a lot of these mental health symptoms are not, this is not clinical anxiety and clinical depression in many cases. It's an increase in scores on standard depression and anxiety scale. So I think in many cases these are subclinical symptoms, and they don't relate to the cognitive impairments, again suggesting that these 2 things are perhaps neuropathologically dissociable. It's not because you're anxious and depressed that you have problems thinking after you have COVID-19 infection. So it's something quite different. Again, short-term memory is fairly robust. It doesn't relate to either physical symptoms or mental health symptoms, and in the general, it is unimpaired. One thing I forgot to say is, although the cognitive health symptoms are related, although the cognitive impairments are related to the physical symptoms, that doesn't mean that only people who are hospitalized in the ICU are going to get cognitive deficits. In fact, we saw significant impairments in people at every level of the scale. So even asymptomatic people were exhibiting cognitive impairments relative to people who had not been exposed to the COVID-19 virus, although these things were very much worse in those participants who had the most severe physical reaction to the virus. So I'll conclude now. I've said it already. 2 factors characterize people's questionnaire responses. One was mostly comprised of physical components like fatigue, pain. The other was related to mental health components like depression and anxiety. And our objective measures of cognition related to the physical, not the mental health symptoms. And I won't belabor that point again. I think I've made it pretty clear what we mean by that. So again, it appears that there may well be 2 types of COVID outcomes. And I think when we start to talk about things like long COVID, we need to think about this. We're not talking about perhaps one syndrome. Perhaps we're talking about 2 or even more things. In our hands, one of them is very much related to the physical and cognitive outcomes from COVID-19. The other is related to mental health, to anxiety and depression. I haven't mentioned the longitudinal piece. I'll just say one word about that. As I say, we can't tell you what the 12-month data is, but what we can do is, of course, look at the amount of time between somebody's diagnosis and when we tested them. And at the moment, we see no relationship between how long it is since you had COVID and your cognitive profile. That may suggest, if you put a positive spin on that, it suggests that the deficits aren't getting any worse over time. That's a good thing. But of course, it also confirms that they probably aren't getting any better over time either. And that, of course, would be a terribly bad thing. So I can't end without acknowledging my collaborators, Rick Schwartz at Sunnybrook in Toronto, David Menn in Cambridge in the UK, Connor Wild and Loretta Norton working with me here at Western, and David Richman in Ottawa. Thanks very much for your attention. I'm very happy to answer questions.
Thank you very much, Adrian. You were also amazingly on time. So we are just done within the frame that we planned to have the symposium in time-wise. So if it's okay with you, there are some questions, and I invite everybody to look for answers in writing. Just one question: who can participate in the study that you described, your global COVID brain study? Yeah,
that's a great question. We're still going. Anybody who has had a confirmed diagnosis, so don't participate if you just think you have, but if you've had a confirmed diagnosis, sign up. The website is covidbrainstudy.com. There you go. I remembered it. It's not hard. COVID brain study, all one word, covidbrainstudy.com. Anybody who's had a confirmed diagnosis can sign up. And you'll learn a bit about your own cognitive function. We feed back information to people. So if you want to know if you're not operating as well as you should be cognitively, then sign up and find out for yourself. We'll tell you how you're doing.
Thank you very much. We have shared your invitation to participate in that study before, and we'll post it again now that it's become relevant again. Thank you. I will now conclude this session. I think we've broken the ice perfectly. It was a great symposium, and I'm looking forward to the next one. Thank you.